Good afternoon. I'm Michelle Boss, the Director of the Department of Healthcare Services. Thank you for joining us in today's conversation on value-based care. At DHCS, our purpose is clear: to expand access to high-quality, equitable, whole-person care for our Medi-Cal members. The recent enactment of H.R. 1 and other federal changes and state budget pressures are resulting in sweeping changes to the Medi-Cal program, threatening this mission. Specifically, provisions in H.R. 1 result in millions of Californians losing Medi-Cal coverage, straining an already stretched safety net of providers, and likely result in clinic and hospital closures, worsen access to health care, and ultimately worse outcomes for Californians. Additionally, provisions in H.R. 1 and other new federal regulations are changing how California can pay for its Medi-Cal program, reducing overall funding and introducing strict restrictions on state-directed payments. In face of these dramatic changes and funding shortfalls, California must make sure our taxpayer dollars are being spent on healthcare that actually prevents illness and improves member outcomes. While the department has been shifting towards this type of value-based care as part of our broader Medi-Cal transformation, the current federal changes make it no longer optional. A value-based strategy now is a necessity for the department and the Medi-Cal system to maintain and improve health and well-being for our Medi-Cal members. Today's webinar introduces the current state and federal policy environment that is driving many of these changes and introduces DHCS's value strategy work to align incentives with the outcomes we seek: improved access to primary and behavioral health care, reduced disparities, and better coordination across the continuum. We will keep engaging providers, plans, and community partners so our policies are practical, data-driven, and responsive to the diverse needs of Californians. I want to thank each of you for your partnership in advancing a more equitable, person-centered, value-driven Medi-Cal system, and to the DHCS team for leading this effort. Together, we are building a foundation for better health outcomes for all Californians. We cannot afford to not do this. With that, I will turn it over to talk to Dr. Paula Bavaria.
Thank you so much, Director Boss, for kicking us off with those words of wisdom. Hi, everyone. My name is Paula Bavaria. I'm DHCS's former Chief Quality and Medical Officer. We can go to the next slide. And here to just orient you and review our agenda for today. So you've already heard from Director Boss and myself. We can go to the next slide. You will also be hearing from our Susan Phillip, our Deputy Director for Healthcare Delivery System, from Raphael Davtian, our Deputy Director for Healthcare Financing. Go to the next slide. As well as from our brand new Chief Quality and Medical Officer, Dr. Chris Escara, who will be joined for a Q&A and fireside chat portion with Colleen Murphy, who is the current Chief Operating Officer at Health Plan of San Mateo. We can go to the next slide. So a few words of housekeeping before we get into the content. So for anyone who has registered for this webinar, we will be emailing you the slides. And then in the next few days or weeks, the slides will also be posted publicly to the DHCS website. In order to stay on track, all participants' microphones and video have been disabled, but we absolutely want to hear from you. And so we do have, I believe, an open chat that all of you can type into. And we will also have a Q&A function. So as we go through, we want your feedback, we want your thoughts, we want your questions. This is going to be the first of probably many webinars and many future engagements. So use the chat actively. We will save it and it will inform our future policy and stakeholder engagement. And then if you have specific questions that you would like the presenters to answer at the end in our Q&A portion, there should be a Q&A button at the top that you can enter your questions into, and we'll try to get to as many as time allows. If you have any other questions that aren't answered today, you can also email vbp@dhcs.ca.gov. Go to the next slide. So we're going to be covering a number of topics. As you heard from Director Boss, there are a number of rapid changes happening with great impact to the Medi-Cal program, both at the state and federal level, which is making this value strategy much more urgent and necessary than it's ever been before. We'll talk a little bit about how the department is defining value in healthcare, as well as where Medi-Cal is today, and then really lay out the framework of what you can expect to see coming out of DHCS in terms of various strategies and policies in the weeks and months to come. We'll then do a fireside chat with our partners at Health Plan of San Mateo, who've actually been implementing many of these strategies and priorities for years to see what this looks like in the real world at the managed care plan and provider level. And then we will open it up for Q&A with all of you. Go to the next slide. So I am thrilled to present Raphael Davtien, who's going to kick us off for this next section.
Thank you very much, and good afternoon, everyone. I'm Raphael Davtien, Deputy Director for Healthcare Financing at the department, and I will spend the next several minutes sharing a bit about why a Medi-Cal Value Strategy is needed, and particularly why it is needed now. Next slide, please. One of the key factors driving the need for a value strategy is the growth in costs and associated financial pressures that we are seeing in the Medi-Cal program and within the context of the broader state budget. Medi-Cal provides healthcare coverage to over 14 million Californians. We are the largest healthcare coverage provider in California. We are the largest healthcare payer in California and cover a broad range of services, including physical health, behavioral health, pharmacy, long-term care, dental, hospital, etc. We are also within the state. The Medi-Cal program is the largest state program when considering total costs, accounting for a significant portion of total state spending, as well as a large portion of general fund spending, second only to K through 12 education. Next slide, please. In recent years, there has been significant and rapid growth in Medi-Cal costs. Spending under the program has more than doubled over the last 10 years, and our share of the total state budget is growing as well. The latest budget that was passed and signed for the 2026-2027 fiscal year is projected to or reflects projections for the Medi-Cal program to reach an all-time high in terms of total spending. Next slide. There are a number of different factors that contribute to this growth in spending. Certainly, enrollment is part of it. Increased enrollment is part of it. Medi-Cal now, we are proud to say and happy to say, covers more members than we did 10 years ago. However, growth in enrollment is only part of the picture and is not the primary reason for, is only part of the picture and doesn't explain all of the growth in spending. What we are seeing is that there is also significant growth in costs per member, which has driven much of Medi-Cal's total spending growth. Some of that is due to an expansion in the scope of coverage, more services being covered than were before. But again, that is only part of the picture, and some of it is just growth in, a lot of it is just growth in the cost of services that historically were covered. A value strategy in this context, against this backdrop, a value strategy is intended to and can help us ensure that the resources we are investing, we as a state are investing in the Medi-Cal program, result in the necessary improvements in health and wellness that we all desire for our members. Next slide. As Director Boss mentioned, we are at a rather pivotal moment. There are multiple pressures that are converging, multiple financial pressures that are converging now to make the need for a value strategy ever more pressing. There is reduced federal funding as a result of various federal changes, including and especially HR 1. There is reduced federal support across a range of Medi-Cal policies. There are impacts on Medi-Cal eligibility, financing, payment levels, and other changes, some of which have already taken effect with HR1 and subsequent regulatory action by our federal partners, and others which are still in the process of being outlined or implemented, or are scheduled to go into effect in coming years. There are changes to federal regulations that significantly impact how we are able to administer and fund and finance our Medi-Cal program. Specifically, changes in 2024 impose significant restrictions on how we can pay for services in a managed care delivery system where the majority of Medi-Cal members receive care today, and impose significant restrictions on a payment mechanism called state-directed payments, which I will talk about in just a moment, that represent a major source of funding for Medi-Cal providers, and especially for hospitals that provide critical care and access to our members. And then lastly, there are, of course, state budget constraints that, as many folks I'm sure know, have resulted in recent state budgets, including multiple changes to coverage and benefits in Medi-Cal within recent years. And we continue to see growth in base spending and annual base spending costs in the Medi-Cal program, just that continue to add to these constraints and pressures. So all of these financial pressures coming together really make a value strategy urgent, not just important, not just valuable, but urgent at this point in time, to enable us to ensure that we can provide high quality care and positive health outcomes for Medi-Cal members despite these financial challenges. Next slide. So I do want to take a moment to talk about what state-directed payments are and why we're focusing on state-directed payments in today's conversation rather than talking about Medi-Cal payment more broadly. As we think about a value strategy, let me start by saying, as we think about a value strategy, we are thinking about Medi-Cal payment and how the Medi-Cal program works more generally. The reason we're focusing on state-directed payments particularly is because this is an area where there is a significant amount of change that we are required to undertake in the very near future. State-directed payment programs are specific payment arrangements that allow the DHCS, in certain limited circumstances, to instruct or direct plans how to pay their providers, or what to pay their providers. Generally speaking, state Medicaid programs are prohibited from doing so, but there are certain pathways or circumstances when that does become allowable. And there are a number of state-directed payment programs that the Medi-Cal program utilizes to steer payments or direct payments to particular purposes for particular services. State-directed payments are subject to approval by our federal regulator, by the Centers for Medicare and Medicaid Services, or CMS, and they do provide a major funding source within the Medi-Cal program to a range of providers, and especially to hospitals. A longstanding requirement of state-directed payments has been that they support the comprehensive quality strategy that DHCS develops and publishes every 3 years. Next, please. In 2024, CMS finalized regulations, a final rule as they call it, to establish new and additional requirements for Medicaid programs pertaining to a range of arenas, but particularly focused on changes to state-directed payments. The 2024 rule limits how DHCS can pay managed care plans through state-directed payments in ways that were not limited prior to 2024, in ways that where we previously had more design flexibility, and additionally increases requirements and expectations on the Medi-Cal program to show that state-directed payments are achieving the goals of the comprehensive quality strategy, not just that they are merely aligned with those goals, but that they are actively achieving or helping to achieve those goals and objectives. Last year, HR 1 was signed into law on July 4th and included a number of provisions limiting Medi-Cal financing and Medi-Cal payment. Among them, limitations on new state-directed payments to not exceed 100% of Medicare rates, restrictions on existing state-directed payments that exceed Medicare payment levels to be phased down over time, and restrictions on provider tax regulations that have historically served as an important revenue source for the Medi-Cal program and for other state Medicaid programs. Next, please. As we look ahead at the future state of state-directed payments, we come to a few inevitable conclusions. The first is that our existing state-directed payment programs include many historic elements that are not well aligned with where we are looking to drive the Medi-Cal program. For example, for hospital services, while hospital state-directed payments remain a critical funding source to preserve necessary access to hospital care for Medi-Cal members, there is unevenness within the current design of our state-directed payment programs, where we tend to provide better reimbursement, for example, for hospital inpatient services as opposed to outpatient services, and where many of our hospital-directed payments currently tie more to the volume of services than to the quality of care or to the health outcomes that are achieved for members. These are in and of themselves not necessarily fatal flaws when considered as part of an overarching financing and payment strategy, but they are vulnerabilities, and they do result in they do drive incentives that are sometimes misaligned with or counter to the care outcomes we are looking to create. The other inescapable conclusion is that state-directed payments must be redesigned to support Medi-Cal's comprehensive quality strategy and our value strategy in order to continue to exist, to continue to comply with new federal requirements, to make the best use of limited Medi-Cal funding, and to effectively align the financial incentives that we create through these programs with the underlying central fundamental goal of essentially everything that we do of improving member health and wellness. Next, please. I mentioned earlier that state-directed payments are a component of what we are focused on. The reason we are focused on them right now is because of the intense federal pressures to take action in this space and the active changes that are occurring and in the federal regulatory and other landscape governing state-directed payments. However, this work and this thinking is part of a broader momentum, a broader effort to drive value within the Medi-Cal program and across the state, across the state at large. There are multiple efforts underway, some federally driven, many state-driven, to work on value in healthcare broadly, and we are working with our partners at Covered California, CalPERS, and the Department of Healthcare Access and Information's Office of Healthcare Affordability to seek alignment, to find and pursue opportunities for alignment where that alignment can help us strengthen the impact of the efforts that we are collectively undertaking. Next, please. I spent a good amount of time talking about costs and financial pressures. I do also want to talk for a few minutes about results and outcomes. Next, please. A fundamental precept of a value strategy is the notion that payment be connected to results and outcomes. And so as we think about a value strategy, a core component of that thought process is looking to take a more deliberate approach to how Medi-Cal operates as a purchaser of healthcare services for our members. And so we are actively seeking to establish more robust frameworks wherein we continually ask ourselves in every program, in every initiative, in every decision we take, how does payment improve care delivery? How does payment incentivize the services and the behaviors that are going to help improve member health and wellness? How do we use payments to support access, to support quality, population health, and care management and coordination, and being aware of the practical realities of costs and financial constraints? How do our payment strategies ultimately help to manage overall costs while ensuring members get the high quality care that they need and deserve? Next, please. As we take these steps and as we think about these questions, we do so with a recognition that every part of the healthcare system plays a critical role, from primary care to prevent illness and manage chronic conditions to specialty care that's needed to address more complex health issues, to behavioral health and maternal care that integrates physical and mental health care and is necessary to ensure high quality birthing care and positive birthing outcomes, to hospitals and long-term care and home and community-based services who provide the necessary acute care or institutional care or equivalent services in a community setting for members that may be experiencing an emergency or other significant acute or long-term health crisis or need. There are of course more than just what is listed on this slide. To be clear, value-based payment and a value strategy does not mean that the goal is to drive every service or move every service into a particular setting. It is not meant to replace one setting of care entirely or even primarily with another. Rather, it is intended to ensure that members are getting care where it is most appropriate to get care, and that every part of the overall healthcare system is supported in doing what it is designed to and best suited to do. As we will talk about later today, the goal fundamentally is to get members the right care at the right time in the right place or setting with the fewest gaps between settings across the continuum of care. Next, please. Finally, as we think about what a value strategy does or what it is supposed to do, it is in many ways fundamentally a framework for decision making, a framework for design, a framework for how we structure and implement and administer programs. A framework that is intended to ensure that funding and payment align with that central goal, that central purpose of improving members' health and wellness as effectively as possible, with the goal being a system where payment is directly tied to and directly supports timely access, care coordination, preventive care, improvements in member and population health outcomes, while ensuring that we are using Medi-Cal funds and state and federal resources economically and efficiently, and providing the necessary access to high quality care to our members, including high quality emergency hospital, nursing facility, and other costlier care when needed, while also providing the necessary upstream interventions that prevent the need for these services when they are avoidable or not needed by our members. And in that way, again, attempting to create the conditions for care to be provided to our members where it is most appropriate. Next, please. With that, I will turn it over to Susan Phillip to continue the next part of our conversation.
Great. Thank you, Raphael. Good afternoon, everyone. My name is Susan Phillip, Deputy Director for Healthcare Delivery Systems. Thank you all for joining us today. We can move to the next slide. Okay, so as you've just heard, Medi-Cal is really operating in a very different financial environment than even a few years ago. So this reality really makes it increasingly important that every dollar we spend supports the best possible outcome for our members. So before we speak about the specific strategies that DHCS is pursuing, I'd like to spend a couple of minutes just grounding us in a simple question. What do we actually mean when we say value? So as Raphael touched on, right, for Medi-Cal, value means achieving better results and better outcomes at a cost that the program can sustain. And you'll also hear us describe value as delivering the right care at the right time in the right place at the right cost. And all four parts of that statement really matter, right? The right care, the right timing, the right setting, and also doing it in a way that allows Medi-Cal to continue serving millions of Californians for years to come. So this definition recognizes that value isn't achieved by focusing only on quality or only on cost, right? It really requires us to improve both together. We know that if we focus just on cost, quality and access can suffer. We know that if we focus only on certain aspects of care delivery without paying attention to cost, inefficiencies, redundancies, and waste in the healthcare system can result. So we really need to pay attention to both aspects. We can move to the next slide. Okay, so this slide really illustrates that relationship. On the left are outcomes we all want to improve: access, quality, member experience, care coordination, care management, health outcomes, which are the results that Raphael was talking about, reducing healthcare disparities, and of course, supporting a strong workforce. These are all measures of success on how we're driving value. In addition, these measures, I will want to acknowledge, are also interdependent. It's difficult to drive quality of care if fundamental access to care is not available. So we really need to pay attention to all these measures. At the same time, we also have a responsibility to use resources wisely. So this means reducing avoidable delays in care, reducing preventable complications, reducing necessary hospitalization when appropriate, and protecting resources so they're available when members truly need them. And a really important point is that these are not competing priorities. Better outcomes and responsible stewardship of resources go hand in hand. So when members receive coordinated, preventative, high-quality care, they often experience better health while avoiding more intensive services that could have been prevented. So they really do go hand in hand. Okay, we can go to the next slide. So this really brings us to the final point here that I'll make before handing it back to Paula. Sometimes we hear people say the phrase managing costs, and understandably, they become concerned because they think, okay, this means we're talking about cutting services. That is not what the strategy is about. Managing costs means using financing strategies effectively and using dollars we spend efficiently. It really means getting greater value from every Medi-Cal dollar that we spend. And it really means supporting a healthcare system that remains, again, sustainable for members, for providers, and for taxpayers alike. It absolutely does not mean withholding necessary care when people need it. It does not mean lowering lower quality of care. And it also does not assume that every provider or service should simply cost less. It does not mean, blanket cuts in costs. That is not what the expectation is. So our focus is ensuring that payment supports high value care while protecting access to services that members genuinely need. So with that shared understanding of what we mean by value, I'm going to turn it back over to my colleague, Dr. Paula Barbaria, who will begin walking us through how DHCS is really translating these principles into a comprehensive Medi-Cal value strategy.
Thank you so much, Susan. And to maybe just give an illustrative example of some of what Susan was talking about, as many of you know, I am still a practicing primary care physician. I see patients once a week at a federally qualified health center near my house. And I think it is fair to say that I have never had a clinic where I don't see some opportunity to reduce low value care and improve outcomes while saving money for our Medi-Cal system. Often I will see patients who are sick because they couldn't get an appointment for a long time. And by the time I see them, their condition is worse and takes longer to get better, requires more tests, requires more medication than it would have been had I seen them a month or two earlier. Often I see people who went to the emergency room or were hospitalized, but didn't need to be, but that was the only place that was open or accessible to them in the evening. And they work during the day and couldn't get in for an appointment. And so, to piggyback off of what Susan was saying, I think the sort of opportunities are endless. And for many of us who are in the delivery system every day, they are visible. But the incentives aren't always aligned to do the right thing that is member centered and save the money and drive more preventative care and avoid some of those outcomes. And so that is really the change that we are striving for in the Medi-Cal ecosystem. We can go to the next slide. So we have made some progress. California has made a number of major commitments really over the last 5 to 10 years. We've expanded managed care in Medi-Cal to really provide some of that flexibility to explore alternative payment models and really think about prevention and care management. We've also expanded coverage because we know that when people have insurance, they will actually seek the care that they need, and often that care is delayed. We also have done a phenomenal job building out a quality accountability infrastructure over the last 5 years and have seen managed care plans invest much more in quality improvement, in population health, and the outcomes have been improving year over year. We also have tried to reduce fragmentation and administrative burden across the ecosystem with many measure alignment and similar contract expectations across the public purchasers, so us at DHCS and our partners at Covered California and CalPERS, to really make it easier for providers in California to have a true north. And then we have a number of increasing programs that actually tie payment to quality performance. We are not going to get into the weeds of all those programs today, but we do have information on our website on all of those, and we'll have future engagements to walk through those. And then we've had a lot of conversations with many of you on this call and other key partners about how do we actually align incentives and improve value, at the state level, at the managed care plan level, and with providers and communities across our state. We can go to the next slide. So the framework that we are using is, I'll walk through where our current programs are and where we need to get to. So all of the approaches in these level 1, 2, 3, and 4 can be applied to any level. So it's something that we can apply statewide at the state level. It could be applied to managed care plans or to individual specific providers or service lines. Some of you may recognize that these are largely bucketed in the HCP LAN framework, which you can read more about online. So level 1 is that really payments aren't tied to outcomes. This is historical fee-for-service medicine, which is unfortunately still the norm across a lot of our state, where someone shows up and someone gets paid for providing services, whether those services were appropriate, inappropriate, good, or bad, it doesn't matter, you still get paid. There's a lot of literature out there that these can often drive towards sort of, high productivity practices, but don't always necessarily actually improve the total health and well-being of a population. Level 2 is really foundational programs where we have programs that can build capacity to improve outcomes and results at the right cost. We know that there's a lot of infrastructure that is needed to provide high value care. You need data exchange. You need a way of knowing who you're taking care of. You need team-based care and ways to outreach to members. So there's a lot of foundation that needs to be built in practices. Level 3 is once you have that foundation, then you can add incentives and accountability, where you can actually tie payment to measures, and so that you can see, hey, if you actually control all the diabetes in your population, then you get paid more than another practice or plan that is not controlling the diabetes, for example. And then level 4 is true advanced value-based payment, where there are more advanced approaches that can sometimes include downside risk, total cost of care. And so it is harder than level 3, but is really, ultimately where we want to get to as a state, because that is the only way we will align incentives so that not only are we providing higher quality care, but we're also reducing a lot of that waste and low value care that is currently happening in our system and is not good for members, not good for taxpayers, ultimately not sustainable for our program. We can go to the next slide. The other big frame shift, in addition to those sort of 4 levels and how we get from the left side where there's nothing tied to quality, sort of true accountable value-based care, is that in current state, we acknowledge that we have a lot of different programs and policies. They have largely been developed in silos over time, over decades. And sometimes they work across purposes where we're, have a policy over here that is great, is working, and another one over here that's great and working, but they're actually not working synergistically together. And it adds complexity for our plans, for our providers, and sometimes undermines the progress that we are trying to make. So for example, as Raphael referenced earlier, for many of our state-directed payment programs, they work. We invest a lot of money, but then it sometimes results in perverse incentives where the financial incentive is to actually keep the member in the hospital or to have the member go to the emergency room rather than to invest in expanded access and capacity in outpatient centers where the care is more appropriate or cheaper. And so as we move into this future state, we need to look at, and we'll be looking at all of these programs and policies, not as sort of individual pieces, but, part of a larger whole. How do we look at the cohesive programs? How do we make sure that they are all working towards an actual true north? And you're going to hear a little bit more about that in the next section. You can go to the next slide. And so now I am delighted to introduce Dr. Chris Esguerra, who is in the first week on the job as DHCS's brand new Chief Quality and Medical Officer and Deputy Director for Quality and Population Health Management. Chris, it's all yours.
Thanks, Pallav. Right, so we're going to go talk about the Medi-Cal Value Strategy and what exactly is that. We'll go to the next slide. And first, talk about the guiding principles, because you can't necessarily set up a strategy. You were given the why and the reasons why we need to be doing this and some of the framework. And really here, in terms of our guiding principles, we want to just really capture the pieces that actually guide the design. So really here, you've heard about this idea of high value and really thinking about high value services. So incentivizing those pieces that are high value, preventive services, behavioral health, primary care, for example. And then decreasing high cost, low value services. And Susan actually alluded to this in terms of avoidable emergency room visits, avoidable hospital stays, or avoidable high cost care that could have been done in a lower cost setting. In addition to the cost component and really thinking about value is really thinking about the outcomes from a member and a population perspective. And that is very much tied with the member experience and making sure that we have good, solid member experiences overall. And in doing this, that our providers are having a good experience as well as we're reducing administrative burden. And as Paula mentioned, this idea here of aligning efforts overall is really important because when large systems are at cross purposes and have different goals, it makes it very, very hard. So this effort at aligning at multiple levels is really important. And so in the next slide, we're going to talk a little bit about our strategy. So with the next slide. And so the goals here and strategies, we're going to go over these overarching and service line specific strategies, but ultimately we want to be able to improve member health and wellness by delivering right care at the right cost. And so you'll see here just the overall summary of what these are. We're actually going to go through these in detail. So let's go into the next slide. The first strategy here is provide foundational support. So the reality is in California, with such the diversity, not everywhere is resourced in the good way. And so we have to be really thinking about where is it that we need to build capacity? How do we understand what the needs are? And how do we really attune to local community conditions and really think about the work needed to provide that support to providers, to plans, to really get to a place of readiness. And so DHCS, along with other state partners, we are committed to providing technical assistance, enabling support, and policy changes potentially to be able to support this work. Health plans may also be a reasonable source of support to providers, given a lot of the partnerships and work that they already do. Next slide. Our second strategy, investing in primary care and while managing overall costs. So one of the key pieces here, and this has been borne out in a number of studies, there's a National Academies of Sciences, Engineering and Medicine report on robust primary care. And when you fund primary care in a robust way, it's linked to lower mortality, improved outcomes, and lower total cost of care. The unfortunate reality, though, is in the US, primary care spending is unfortunately low, and it lags on high-performing nations. And you see here, it's around 4 to 7%. Generally, in other nations that are performing well with better outcomes, it's 12 to 15%. So for California, it's unfortunately low. And so we know that we need to be investing and spending in primary care and other high-value services. So again, behavioral health, preventive care, addressing social needs. These are the pieces that actually get, once invested, we know we're going to get really good outcomes. In addition, we need to be thinking about decreasing unnecessary and preventable spending on what we on what we want to see less of. And so we've talked about that, unnecessary hospital stays, unnecessary emergency room visits. The next slide. So coming soon, we will be having an all-plan letter on primary care spending and value-based payment adoption at the VBP. And so this will be an all-plan letter that will require managed care plans to meet specific expectations for increasing primary care spending and value-based payment contracting with providers. This is already work that's been happening with the Office of Healthcare Affordability, OHCA, and its framework. And managed care plans will be expected and are expected to achieve these goals, not by increasing costs overall, rather by rebalancing how they direct their funds towards what drives value and reduce costly or avoidable services. Next slide. Our third strategy. So it's all about alignment and alignment of expectations across plans and providers. And so that as long as we are all working towards the same goal, we know we can achieve success. And so this means that incentives, accountability must be similar across all plans, providers, wherever possible. And so as alluded to earlier, this has been work that DHS has been doing with CalPERS, with Covered California, and other agencies to really push on this alignment, in addition to other areas to be thinking about this. And so one way is to be thinking about a single list of common key performance indicators, and really thinking about this as just something that where we can focus on, and it creates a common starting point for new policies, programs, and rather than the siloed aspect that Paula had previously described. And so this expands beyond the idea of quality measures alone and gets to a broader concept of what is value and what is a valuable outcome. So DHCS has begun this process, and the KPI list will be published in the future. Next slide, please. So the structure here will be an overall short list of key overall KPIs, and then with some subsets related to outpatient services, outcomes rather, acute care outcomes, and post-acute care. Next slide. Strategy 4. So again, you've seen these levels and this idea here for what Paula described, but really thinking about the evolution and scaling value-based payments across plans and providers. And not to belabor the point here, but the idea of moving to just paying for a service with no results or tying to it and getting to something much more sophisticated. Understanding that we need to be thinking about foundational work and capacity building that gets everyone to that capability where we're thinking about accountability and advanced value payment models. And again, you can look at this as the HCP land model, and that has a lot more details. But the idea here is to go to the higher levels, level 3, level 4, ideally. Next slide, please. And to the service line specific value strategies, we can't forget about these particular areas. Front and center here, you see primary care and maternity value strategy. This is underway with the work with the Population Health Learning Center, specifically with primary care and the VBP model, and the Transforming Maternal Health Project. There's a lot more on this. We have a link here in our slide, but it's definitely on our website. Do check it out. For the skilled nursing facility value strategy, there is already active work with stakeholders, and so there will be a report forthcoming, and so be on the lookout for that. And the hospital value strategy, we currently have closed the request for information, and we are finalizing the selection of potential contractor. So this is work that will start later this year. Next slide. So we're going to just wrap up and then get into a discussion. And so into the next slide. Really, what we are trying to do here is have a cohesive strategy that is aligned and that drives value. And again, in summary, Medi-Cal is facing unprecedented financial pressures. You heard about all of those pieces, but the reality is a value strategy is needed to make sure every dollar spent in Medi-Cal is used efficiently to improve member health and wellness. So this value strategy, this Medi-Cal Value Strategy, provides a clear framework to drive value across plans and providers over many years to come. DHCS intends to monitor and evaluate whether efforts under the value strategy are working and or having unintended consequences, and so therefore adjust as we need to. Next slide. And again, here, you will see this image regularly going forward. Our overall goal and strategies here, and we will continue to talk about these and really move this forward. But as, again, you see overall where we want to be able to have the focus and in terms of our goals. Next slide. So next steps. So stakeholders, for those of you who are joining and those who are watching this as a recording, you should definitely review the value strategy and consider the following. What readiness supports do plans and providers need? As you can imagine, that's going to vary based on where you're located, what resources you have even locally, and that is an important discussion and consideration. The other piece here is, what is each stakeholder's role and what is the role in advancing the value strategy? Everyone has a role in this. No one individual institution can actually do everything. And so this is a community effort where we all have to work together. And where can payment better support members' health and outcomes, and really keeping that center? Ultimately answering the question, for whom do we all exist? We all exist and come together in community for our members, for our fellow neighbors in California. So DHCS, we will be doing the following. We're going to be engaging with stakeholders, starting with this webinar, but going forward as we have been doing and with more. We're going to finalize a list of KPIs with stakeholders, develop and implement service line specific strategies, work to align all programs and policies with this value strategy, and refine the value strategy, potentially release a written value strategy in the future. So the next slide, we're going to have a little chat with my former colleague, Colleen Murphy. So Colleen, if you can come on.
Hi, Chris.
All right, there we go. Glad you can join. Okay, so Colleen, at Health Plan of San Mateo, if you first can talk a little bit about and introduce Health Plan of San Mateo, and then perhaps talk a little bit about how I started with the framework. If you could talk a little about the investment criteria and the framework, how you all been thinking about value.
Yeah, absolutely. So delighted to join folks today. I am here in my role with the Health Plan of San Mateo, which is one of the smaller managed Medicaid plans in California. We serve currently around 130,000 folks here, and both serving a Medi-Cal population as well as a dual eligible population. And I will start off a little bit of that question of kind of our strategy. I think the point that you closed on there is a really helpful thread to this, which is for whom do we exist and why? And if I think a bit about what has really informed our our strategy, it is exactly that question. And for us, that was actually a decision a few years back that was not a hard decision. I think it actually built upon some past work, but to really center this goal of providing healthcare that rivaled the outcomes and experience that one might have if you had commercial coverage. I think for folks listening in, that may either sound like a radical, impossible idea or completely underwhelming. I will say, if like me, you have seen Medicaid coverage personally or front and center, or whether that was yourself or helping family members to navigate coverage when you really needed the safety net to work. Hearing someone say, I really want your mom to be able to have the outcomes and experience of care that anybody with commercial coverage would have is probably not particularly revolutionary. And if you are listening to this, though, through someone who maybe serves the safety net today or works in the managed care space, and faces some of those realities of really serving a population that often has much more complex needs, and sometimes doing so with about half the resources, and really needing to be very thoughtful and intentional with how we spend those resources, that can feel pretty challenging of a goal. But with all of that kind of all of those footnotes on that is really what we set out to do, and that has informed some key pieces of our strategy, both in how we prioritize our investments and then also how we use our time, whether that's on data sharing or really kind of that more foundational support for our providers.
Well, and one of the things that you touched on, and I think I'm going to ask you to go into it a little more. When you think about this work and really think about value investment, it starts to feel like there's so much to do. How do you think about the prioritization?
Absolutely. And again, and that prioritization in this constraint of limited resources that are even more
Absolutely.
now under threat in the environment that we're in. I will actually share a quick visual on this one. If we can jump to the next slide here. There is both an art and a science to trying to balance some of that. And again, where we're kind of coming at that question of if this is our ultimate goal, how are we best using limited dollars, the privilege of the data that we have? So again, as a managed care plan, we often are the central point for really rich data. And also, how are we using our time with the relationships that we have as a local plan that's really deeply connected with our other safety net partners? This kind of 2x2 here, it has been really helpful in making some of those decisions. And really it is for us, especially around provider investments. So when that comes to value-based payments or other types of financial investments, looking at both the priority for and pain points for our provider network, how are we really fortifying access and the long-term sustainability of the safety net, looking at specific areas like things like outpatient payments or other areas where rates in a Medi-Cal environment are pretty far afield from kind of commercial coverage or Medicare. Looking at that as a factor here, and then very rigorously looking at our member access needs. And again, we do that through both quantitative and qualitative work. I am lucky to work with some fantastic colleagues who do this with great enthusiasm and really with a lot of data, but both looking at factors like, where do we see access gaps on paper? We don't have enough of this type of provider here in this geography, serving this age group. Really, you can kind of see some of that concrete data there, and we collect a lot of it. But then also seeing, where are we seeing those gaps in practice? Where are we seeing folks have a lot of grievances about their level of access, or they're having to go out of network and find a little, a service level agreement for a provider out of county to get this need met. Or we're hearing from our community partners that this is an area that is really challenging, and bringing all of that together to prioritize with rigor and with regularity, what are those top needs for our membership. And I will say, to spoil the punchline there a bit, that little call out in the top right is one that's really remained true as we've looked at this both quantitatively and qualitatively, and that is a heavy focus on primary and preventative care, including behavioral preventative care, some very specific critical access gaps, and those tend to differ by geography. And then also some components of specialty physician fees, where often, again, that's just built more into the financial structure of Medi-Cal reimbursement, but that can be a challenging area sometimes for really getting access to specialty care.
I appreciate that. And I'll say, and I'm definitely going to lead you into the next slide here, but I've had the privilege of working with you and with Miriam Scheinbein, HPSM's medical director, on this primary care and the primary care investment. And again, thinking about, the levels that we've showed is really this idea of you need to understand where you need to build out before you can ask folks to perform when we're talking about value. And so, Colleen, if you can talk about primary care investment and thinking about the goals, but also how this happened and the work.
Yeah, absolutely. And with a huge thank you to a number of folks at HPSM who've really driven this work, including Dr. Scheinbein, who is herself a primary care provider as well. The goals here are these four, both color-coded a little bit, but really thinking about some of those same themes, right, of how do we better allocate very limited resources, but really trying to use those resources to drive value rather than just volume. How are we thinking about supporting that provider workforce? Again, primary care in particular being under attack right now with maybe strong words, but words that I would stand by as we think about just the workforce shortages there and many of the challenges facing primary care in particular, including underinvestment. And then improving population health and the care experience for members and for care teams. So again, with those kind of goals in mind, to answer the question of more of the how we got there, this was a pretty, I would say, deeply engaged with the community and design-centered work that Dr. Scheinbein and Lorani Bermudo and others at our organization led to really listen and capture both insights from experts in primary care financing and kind of design, as well as really hearing from our provider community about what was not working today. And that has helped to shape more specifically and concretely a set of investments that have a mix of funding for capacity building. So some data sharing, how do we make it easier for folks to get the right data at the right place at the right time to actually do something about it? Some workforce bolstering. So how would we actually help people hire and attract talent here? And really, again, those insights that came from that provider feedback were crucial to that of figuring out where that was getting stuck. And then also just some pure funding to address that underinvestment over time of how do we make sure that this is appropriately resourced, knowing that, again, as you've touched on, there's so much research to support the fact that this is an area where more dollars in primary care results in better outcomes. And that is a win-win-win, I would say, for many of the goals that we are all trying to balance today.
Oh, that's wonderful. And I just want to underline something here because we mentioned it a little bit before in terms of really engaging with different stakeholders and having partners. And we could talk a little bit about that effort. And I said a little bit, but it's almost this raising it regularly of the community effort. No one institution or any one individual can tackle all of this. So if you can underline that a little bit, and then I'm going to ask you the next question on how do you get this done, implementation. But let's start first with just the bringing folks together part.
Yeah. Oh, and goodness, that theme I think can get as broad as we want it to in this fireside chat here, as I'm imagining our fire crackling next to us. There's a Atul Gawande quote that probably folks here may be familiar with about just the complexity of healthcare is something that no one clinician or individual could really tackle alone, but teams of clinicians and teams of people absolutely can. And I think we have really seen that as we're trying to, again, come back to how do we use limited dollars to the greatest effect. Trying to ask this question, and we actually did this with our governing board, our commission. We looked through where are these top needs in the community, not just within HPSM's kind of view of our members, but if we're looking at the county more broadly, where are the needs assessments that our local hospitals have done? What has our board of supervisors been focused on? And really, where do we see core needs in the entire ecosystem that don't have resources dedicated to them today. That helped us in two ways. I think both, one, to reduce any potential duplication. So not looking at areas where we already have partners on first who can do that work with greater expertise than us. But it also actually surfaced some areas that I think were not front and center, at least for me and for many of us in the room, as we were really kind of thinking about what is that one link in the chain that breaks and can prevent someone from getting the healthcare that they need. I think we even saw some of that here in the chat today as well, just folks thinking about that broader system. What is the capacity for transportation, food, housing, navigation? We are not in this alone. It does get complicated quickly, and I think that there is in this work a need to kind of rigorously reprioritize and come back to those top priorities. But it's certainly highly connected.
No, definitely, and it's an ongoing discussion, it sounds like, right? And one where even those with power, without power, without authority, yet participating, have to be able to have those vulnerable discussions, knowing how everyone contributes. One last question before we open it up for questions for folks. This all sounds lovely. This all sounds wonderful. Very, very high goals. How do you start thinking about implementation?
Yeah, it's the moving from theory to practice is always the most important part of all of this. I think that so I will just caution, there's I think a lot of great intent, and setting the goals appropriately is crucial to all of this. But a perfectly designed program, then this applies very much to value-based payment programs as well. I will say in past lives, having seen some very complex economic models for how those dollars get out the door, you can have something that works great on paper and really seems to be targeted at all the right stuff. And if you don't really do the ground game of rolling this out to folks who actually can make decisions that get you to value, it goes nowhere. And you will just have dollars passed through. And again, I think that kind of that theme came up, of perverse incentives, and kind of there will be a movement in the system to kind of take it, orient around some of those incentives without always balancing the full picture of health. And so I think how you counteract that and how you actually get some of this off the ground and move from theory to practice is a lot of communication. So I think there's a really kind of core component here, not just in engaging folks in the design, so that intentional design we talked about of bringing stakeholders in, figuring out where there are gaps in the system as a whole and focusing there. But also being intentional about understanding your phasing of capacity building. So how do I need to invest in baseline data sharing? What are those core areas where there is a very different set of stakeholders if you're talking about a large practice that's a multi-specialty practice, or associated with an academic medical center, and they have a ton of internal resources and folks running data and really tweaking their EMR. And then you move into working with a solo practitioner who's running a primary care practice that they've been running for decades all by themselves, and they are all of those roles. They are a biller. They are many, many things. Those are entirely different needs, and I think unless you've done some of that work in where do we have the biggest capacity gaps and how do I get really intentional about supporting folks that may not have that bigger infrastructure, that design doesn't get off the ground. Then the last piece of it is just early, often, and highly transparent communication. This is just, and you can't do this once and forget about it. It is we need to really tell folks what are the things that we are, whether that is an incentive program. I need to make sure that this complicated financial program is really clear to the folks who are actually scheduling people for appointments. How do we translate that into, again, something people can take action on? And then how do I build that in as a regular practice? And of course, there's the kind of final step in all of this, which is just the iteration. So how am I evaluating whether it worked or not and tweaking it as I go? Did that get concrete enough? I feel like, Chris, I probably just offered a lot of broad statements there, but any ones you'd like to?
Yeah, no, I think that's those concepts capture it really, really well. I mean, so of course, totally offering then that Colleen, you as a resource for folks here in Health Plan of San Mateo in terms of the work that has been done. And I think what we want to do though is I'm sure we can talk about this and geek out on this all day if we wanted to, but we want to make sure we have time for questions. So if we look at the next slide, I know we have had some folks already putting in the Q&A, but if you see the Q&A button at the very top, not in the chat, go ahead and submit your questions there. And Colleen and I will go off camera, but we believe we already had some questions submitted and some folks will start tackling them.
Yep. Thanks so much, Chris. I'm Jeff Norris. I'm the Value-Based Payment Branch Chief at DHCS, and I'll be helping to field some of the questions to the group. So the first question is from Michelle, and the question is, can you explain using specific examples how the restrictions and requirements of state-directed payment programs prevent DHCS from achieving the goals of value-based care?
I'm happy to take this one, Jeff. A great question, and a great question with a complex answer. At a state level, a lot of it comes down to the fact that the healthcare market in California has evolved, and more critically, the Medi-Cal program has evolved significantly over the last decade. We have more members, we cover more services, we have significantly transformed how Medi-Cal operates under CalAIM, and our payment programs and methodologies have not always kept up. For example, we've focused a lot in recent years, or in the last 10 years or so, on maintaining or improving payment for inpatient care to be adequate, but payment for outpatient services has lagged behind. At a federal level, Medi-Cal payments are typically funded with a combination of state or local funds and matching federal funds, which means we need federal approval of our payment models, methodologies, and programs. And getting approval is hard, and it's becoming harder. The 2024 rule made it harder. HR1 made it even harder. And in addition to the administrative complexity of getting approval, the federal risks the federal risks and challenges to approval are continue to increase, and those are further exacerbated. Those risks are further exacerbated by HR1's reductions in Medicaid as HR1's reductions in Medicaid funding start to be felt. I think, as we think about where we are going with state-directed payments, and more generally where we are going with our value strategy, we recognize and we ourselves see change as being hard and challenging, especially when we are all dealing with so much change already. But we are coming from the perspective that inaction, trying to keep everything the same, is simply not an option. We cannot afford to sit and wait until CMS stops approving our currently structured programs. We cannot sit and wait until our Medicaid funding continues to be shrunk or pressed without preparing for or adapting, making the necessary adaptations to be able to continue to provide necessary care and access for our members. And failure to act would be a disservice to the members we serve, to our partners as well, to our plans, to our providers, to our entire delivery system. If we do not act, we will be jeopardizing federal funding. We will be jeopardizing access to care and member health. And so as we think about this globally, and think about this movement to value-based care, and are embarking on discussing, developing, implementing, and iterating our value strategy, we recognize that there's a delicate balancing act between protecting existing support and existing processes while we pursue improvement. And so our focus is really on finding that right balance and maintaining that right balance between preserving as much as possible Medicaid funding for our providers and for services, pursuing payment structures that result in adequate and sustainable payment for services, aligning financial incentives with appropriate care delivery, and reducing the fragmentation we've talked about a bit today by aligning how we pay and what we pay for to a coherent quality and member and population health strategy. And so again, when we're talking about value, our lens is not about reducing spend. It's about taking steps that recognize and acknowledge the financial pressures we're facing to preserve and protect our delivery system and care for our members, and to try to use every dollar optimally in furtherance of the goal of improving our members' health and wellness. And I also want to acknowledge Colleen's point about converting theory to practice, and assure everyone that we are envisioning a collaborative process. We're not ivory tower decision making, and that is why we're having this high level conversation today, why we're approaching work through multiple work efforts. For example, in our hospital value strategy, we're taking a phased approach. Right now, the work we're doing is just primarily focused on how do we ensure that we continue the programs we have today for the next year, because as they operate right now, they will not be approved. They would not be approvable without certain changes. We're perfectly on track to make those changes and have an approvable program come 2027. But there is work that we are of course doing in that space. And as we think more broadly about our hospital value strategy, the hospital work stream of our value strategy work, we are bringing on a contractor to help launch really a multi-year engagement effort where we can have conversations about what the challenges are, what the pressures are, what the opportunities are, and how we can improve and how we can adapt to the realities with which we are faced. So as part of that recognition, as part of that acknowledgement, I also want to acknowledge, as we're having the discussion today, we don't pretend to have all the answers. There are still a lot of changes happening. There is still a lot of change in the federal landscape, which we're actively monitoring. There continues to be change in the California healthcare market, which we're following as well. And we are kicking off a conversation to look at issues that we see, problems we have identified, opportunities that we see, including challenge. Coming back to the heart of Michelle's question, including challenges and problems in how our state-directed payment programs are designed today, which invite particular federal risk or create particular challenges in terms of alignment of financial incentives to value and to quality and to member health outcomes, and looking to embark upon this conversation and these conversations really to work together towards developing a strategy that is ultimately sustainable, will be successful, and will continue to protect and preserve the best interests of our members.
Thank you, Raphael. The next question is from Tracy. How do you plan to increase managed care plan participation with healthcare delivery systems, or increasing health system collaboration as we care for the same communities?
I can take this one. So I think this goes back to that graph you saw of how we used to design programs somewhat in silos without a lot of coordination. Historically, when we had incentive programs with managed care plans, we would talk about those with managed care plans. And as the department worked on state-directed payment programs with providers, whether those are hospitals, clinics, health systems, we only talk to those, affected providers. Clearly, that does not work because we are an ecosystem and the plans also have their own relationships and incentive programs with the providers and what the plans do affects providers and vice versa. And so DHCS already over the last few years has been integrating those conversations. So the plans are now involved in reviewing and informing DHCS's state-directed payment programs and policies. And for some of our existing hospital-based programs, such as our QIP program, we've actually started bringing plan partners to the table as we work with all of those partners on those quality improvement efforts, so that we can all be in the same room, have the same conversation, and understand from each entity's perspective, what are the barriers, what's working, what's not working. So those are some of the examples of how the state has integrated those convenings. There are also efforts that we are aware of that DHCS is not leading, where plans and providers are coming together regionally and statewide to identify some of that synergy and opportunities. And as we move into this next phase, absolutely, everyone is going to have to have a seat at the table, because from where I sit, I don't see that any of these policies can be achieved without everyone changing something about what they are doing today.
Thanks, Paula. The next question is, do you consider enhanced care management and/or any of the community supports to be part of a comprehensive approach to primary care? And I can take this one. I would say that they can be a part of primary care at the level of an individual provider. Not every provider is necessarily going to have capacity to provide those services directly. And these are a critical part of the healthcare delivery system, ensuring we're directly addressing members' needs as comprehensively as possible. And some of the other questions in the Q&A function get at barriers to care and how we can comprehensively address those. So at the broad level, kind of at not the level of an individual practice, but at the level of the healthcare delivery system as a whole, yes, absolutely. These are a critical part of getting members the services they need. I would say not just primary care, but thinking globally, how do we work with members to improve their health and wellness? ECM and community supports are a critical part of this. And further, those are great examples of high value services. Those are services designed to go upstream and address members' needs to prevent them from ending up in the hospital, ED, ICU, et cetera. And so they certainly are high value services. And I'll open it up to the rest of the panel if you'll have more.
Yeah, just one more thought to add to that is I saw in the Q&A, someone also asked the excellent question of, where is the money for sort of primary care infrastructure supposed to come from? And I think, as you've heard in this presentation, there's no new money, right? We are all collectively entering a period of relative scarcity compared to where we have been. So there is not some magic pot of money that is going to shore up primary care. It is going to have to come from identifying these areas of sort of high cost, low value care. So it is only by driving down sort of unnecessary utilization, avoiding those expensive ED and hospital visits that absolutely could be taken care of in a primary care office at the entire ecosystem level, right? We're going to have to do that collectively to free up the money for the significant primary care investments that are absolutely needed throughout the state. And I think ECM and community supports are both incredible tools in our toolbox to do that. For those of you who haven't seen it, we published an interim community supports evaluation, I believe, last year that showed how use of community supports is cost effective and actually saving money across the state. We have data from our previous whole person care pilots that shows the same for ECM. So those are great tools that are fully funded that we can provide to members that will drive down cost, improve our members' health, and then generate savings that can be reinvested elsewhere.
And just to add something here about the importance of ECM and community supports at a practical level, because it was an interesting question as it relates to primary care and really thinking about it as complementary. Again, ECM is sort of that care management glue that primary care may not always be able to do, especially with that level of intensity and then the services involved, and where even advanced primary care may not necessarily be able to do readily. The other part is community supports as a menu of services, all address health-related social needs. And in fact, kind of going back to way back when I oversaw a little primary care clinic in the Antelope Valley, we didn't have community supports back then, but we referred to our referrals and do these services as the social care specialists. So, we're used to, in the world of medicine, other specialties. I'm a psychiatrist. If we get a referral, or a referral to endocrinologist, things like that. This was a social care specialist. And these are specific types of services that we know, as Paula mentioned, are cost effective, and that are providing these resources and services that otherwise would not necessarily be there or available in the community.
Thanks so much, Chris. Next question is from Sarah. The financial incentive at FQHCs naturally favors seeing more patients rather than doing more within each visit, since they get paid a flat rate per visit. As California moves towards value-based care, what specific payment mechanisms or alternative payment methodologies are being considered to reward FQHCs for comprehensive higher touch visits, like addressing multiple chronic conditions, behavioral health needs, or care coordination in a single encounter without simply cutting into the volume-based revenue they currently depend on to stay financially viable?
So we recognize, of course, that FQHCs are critical safety net providers for Medi-Cal members. Then they are reimbursed differently today because of the unique role that they play and the fact that they do operate differently from other providers. There are a number of different ideas we are thinking about, but really more so looking to collectively think about in the future, including as part of our primary and maternity care service line specific value strategy. We have there are vehicles available that we can explore and potentially pursue to put into place alternative payment models and mechanisms that guarantee FQHCs would be reimbursed no less than they would be under a PPS per visit methodology, but that alter or shift incentives to support and enable practice transformation efforts. We have a number of small APM or APM-like programs in effect or in existence today, and look to build on that experience in the future. In the immediate term or in the near term, we recently began efforts to do some more foundational work in the FQHC payment space by developing essentially a policy guide or a payment policy guide or resource for FQHCs that is intended to, as part of that effort, we intend to gather and compile and organize all of the reimbursement or payment related guidance and information that exists today, so that it is readily available to health centers, and they can see and understand how they're being paid today, or better understand how they're being paid today. But also as part of that effort to identify where there are potential gaps, where there's a lack of clear guidance that we may need to address, and where we have opportunities to provide clarification or provide or make some improvements. And so we've brought on support to do that work. We are envisioning that being a multi-year collaborative effort as well. And so, Zara, to your question, I would say we look forward to more conversations on exactly that point as part of and building upon that more foundational organizational work that we have started with in the FQHC space.
Thanks so much, Raphael. I'm actually going to go to a question from Susan, which is, what's the time frame for implementing all this?
I'll kick us off, and then Raphael, you'll probably have more details. So I think, unfortunately, and partly why DHCS is hosting this webinar is many of the federally required changes to state-directed payment programs, we are expected to go into compliance by January 1st of 2027. There's other provisions that there's a glide path and phase down in terms of making sure we are not exceeding Medicare payments, et cetera. But the changes all start coming January 2027. In addition, we know that some of the ecosystem pressures, such as the rising rate of uninsured, will also start increasing in January of 2027 as work requirements and other HR1 and federal related changes go into effect, as well as obviously with the state budget changes, there's going to be sort of changes in benefit structure. And then many of you are aware, we also have a large number of UIS members who will be moving from managed care to fee-for-service, which will also be disruptive to the system. And so I think despite what many of us have been feeling at the state level and at the local level this year, 2027 is going to be a challenging year. And the sooner we can start having these strategic conversations and planning for the future, the more we will be able to support all of our providers and plans in really weathering what is going to be coming. Raphael or Chris, not sure if you want to add any more specifics beyond that.
I think you covered it, Paul. I will maybe just add there is I think you can hear and sense from us that there is an urgency to this, but also hopefully hear and sense that we are looking to be thoughtful and intentional, not only in rolling out these changes, but the whole underlying concept of the value strategy is for Medi-Cal to be is to make the Medi-Cal program more thoughtful, more intentional as a purchaser of healthcare for members. And so we are actively performing administrative triage. Basically, there are certain changes that are on a timeline of months. 2027 is less than 6 months away, that we are working through. If you were affected by those changes, you likely have already heard from us in some capacity. We've been having conversations for months in the lead up to 2027. There is another slew of changes that will go into effect in 2028. We will begin conversations on those in short order, and some elements of the value strategy will take a much longer timelines, not only because it is important to manage the pace of change, but also because we want to ensure that there is the necessary time for us to have collectively that thoughtful engagement and partnership about what to do, about where to go, and most importantly, how to convert theory into practice, so that we can achieve the results that we're looking to achieve, and minimize unintended disruption to plans, providers, or members.
Hey, last question, or second to last question, from Anne. I am extremely concerned about your comments about state-directed payment programs. They're expected to be cuts by around 40% overall in the next 10 years due to HR1. The comments made today say that you want to shift SDP payments from inpatient to outpatient. This will create substantial additional shifts in payments to hospitals. Many hospitals are already on the brink. How will you address creating more uncertainty and reduce payments that you will be implementing with this strategy against these goals?
It's a fair question. I mean, from our standpoint, again, the lens from which we're approaching the conversation about a conversation on value is not about reduced spending. The growth in Medi-Cal spending is one of the factors that prompts the urgency for a value strategy, but we're not approaching the value strategy as a budget exercise. with respect to the disruption to hospital and more generally to provider payment and funding mechanisms, that is already the reality under HR1. There will be restrictions on how we can pay, on how we can pay and what we can pay. We've been talking about HR1. We are currently CMS in May published a new proposed regulation that proposes not only to codify the changes enacted through HR1, but to also go beyond that and impose further restrictions on Medicaid payment. California will be, or rather DHCS will be submitting a comment letter to CMS in response to that, but the changes are coming. What we are talking about here is how we can best prepare for, adapt and adapt to those changes to minimize the damage or minimize the harm, and most importantly to be strategic in how we use resources, how we use available resources to drive the goals of our program and delivering care for our members, and in supporting the access to care by supporting our providers supporting providers who serve our members.
Thanks so much, Raphael. And with that, we are going to close out questions due to time. We're right at the 5 o'clock mark, and I'll hand it to Chris for some quick parting words.
Right. So with the Q&A, I think one of the things is there's the immediacy of certain specific things, but I don't want that to detract from the overall theme here of value and really thinking about, as a delivery system, how do we work together to identify and really incentivize in an aligned way with all of the appropriate stakeholder inputs into driving high value care with the goals that we outlined and the framework and the guiding principles. And so, yes, we are working towards particularly federally designated deadlines, because that is the reality that we have with HR1 and final rule related pieces. And we can say all those regulatory numbers and letters, but the reality is value is important. And again, back to that fundamental question of we collectively, and definitely as a state, we exist for the services of our members that we serve. And our goal here is to align those services and the incentive structure for those services to be as valuable as possible to achieve outcomes and wellness for those particular members. And so that is our North Star in doing all of this, knowing that this is hard work. There's a lot of it, and that's why it's going to take community and a lot of us working together in order to do this. And so this is but the start of this ongoing conversation. We will have a lot more, and you'll have a lot more communications coming from us, and we hope that there are going to be a lot more of this engagement amongst all of the folks that are trying to do this work for our members.
Thanks so much, Chris. Thank you, everyone, for joining today. We will get the slides emailed out shortly to everyone who registered for the webinar. And again, we'll get a recording and the slides posted on our website within the next couple of weeks. So be on the lookout for that. Thank you for joining us today, and have a good rest of your day.